Happy Monday. It is October 21st, 2024, and we are live streaming right now. We are on the Riverside live stream. We are on Facebook, YouTube, and the X platform. We are excited to have y'all joining us here today. You will be able to interact with the panel, submit your questions. We will do our best to answer those as they come in. With that said, let me say hello to my good friends, Stephanie Howard, Christine Hall, Paul Spencer, and Terry Fletcher. And I'm guessing, Stephanie, since you don't put your last name, you just now want to be one of those artists with one name, Stephanie?
Yes, exactly.
Okay. So, Stephanie. All right.
Or you could call me Allard. I get called Allard a lot, so the mispronunciation of my last name.
Oh,
Stephanie Allard.
Allard.
All I think of
got
is
you.
a bucket of lard.
Okay. Well, with that said, we're going to avoid that so you don't have to take any atorvastatin for your high cholesterol problems. And we're going to jump straight into talking about what gives you other problems, such as behavioral health issues. Let's talk about what's going on with Medicare Advantage, because it was a very big week last week, Paul, and there's a lot going on. There's shareholders that are pissed off at companies for which they hold significant portions of shares or even just one share. We're going to talk about RPM, and we're going to talk about RPM that was put in during the public health emergency and the fact that the PHE, for all intents and purposes, is over, but we have to hold on just a little bit longer until December 31st of 2024 for it to completely go away. But a lot of companies are putting some crazy things in place right now, and I think it's creating some mass confusion. And then we're going to finalize the hour today with Christine and Terry getting in and talking about the difference between the federal and state guidelines, but also paying attention to other commercial payer guidelines and the fact that there's so many variances that exist. So with that said, let's go ahead and jump straight in. We'll start by talking about Medicare Advantage and what's going on there, because JJ Walker and Joe Namath may not be very happy right now.
Yeah. And you can add William Devane to that list.
That is true.
As
well,
well.
I think William Devane's going to be okay because he's doing a lot of the Lear Capital gold commercials these days. So I think he's all right.
Jumping from scam to scam. So Medicare Advantage. We've known in the industry, those of us who follow the OIG audits, that Medicare Advantage basically has a long history, checkered history with inflating coding data and getting money from that inflated coding data. Well, there were three bits of information this week that tells you that Medicare Advantage may not be the best approach for those retirees who are looking for a quote end quote Medicare plan, which they believe they're getting through Medicare Advantage, but as we are learning, there are a number of strings attached. The first issue that came up, and Sean alluded to it a little bit in his introduction, was the fact that CVS, who is a pharmacy chain, and they are looking to close locations around the country, as are other major pharmacy chains. When digging deeper into that story, we learned that the reason why they are having financial issues, so their hedge fund shareholders are whining and pounding their feet and saying, "Where are our profits?" Really stems from the fact that Aetna uh, is part owner of, or a large owner of, CVS, and Aetna's Medicare Advantage business has basically hit the skids this year because they were not expecting the amount of utilization from their patient population that actually arrived, which is leading to financial problems all the way down the line. We also had an appearance from Don Berwick, who was the former head of CMS under the Obama administration, who basically stated that Medicare as a program is in financial trouble, and a lot of those problems can be pointed back to Medicare Advantage plans who are inflating their coding data, which is the way they get paid for treating the sickest patients under the Medicare Advantage population to the tune of $80 billion a year. And nobody's really doing anything about it except issuing audits that say, hey, maybe you're inflating your coding data. And I will remind our listeners that Scott Kraft, just about a month ago when he was on this program, talked about Medicare Advantage plans falsifying information by basically going to medical records and inventing diagnosis codes out of whole cloth based on their expert analysis of medical records for the physicians who have Medicare Advantage populations underneath them. The third thing that happened under the Medicare Advantage umbrella, which is very revealing, particularly as we are coming out of the COVID health emergency, and we remember all of the issues that we had getting people into nursing care, skilled nursing facilities, short-term acute care, long-term acute care. There is now a crisis that is brewing from Medicare Advantage plans insisting on pre-authorization of those services, and services are being denied to people who rightfully deserve to have those services. And there was a report put out by Senator Richard Blumenthal of Connecticut, who really called them on the carpet and took them to task for things like that. Because anybody who's going for services under a standard Medicare program, while there need to be certain clinical markers for a patient to be put in either short-term post-acute care or long-term post-acute care, a pre-authorization process has not been part of that. So the noise around Medicare Advantage has certainly increased this week. It should be concerning that we now have a situation where more than 50% of Medicare enrollees are under a Medicare Advantage plan. And it is time to really start talking about where we go with this and the effects on the program and the effects on the long-term funding of the program, which is the most important thing.
Well, I think one of the things to keep in mind is, and as we've talked about, by 2030, Medicare really wants everybody to be off of Medicare Part B and onto one of these managed care programs, which I think would be a complete catastrophe. I had an opportunity yesterday to have a conversation with an incredible couple, and the husband has suffered a couple of strokes, had open heart surgeries, got a lot of chronic illnesses, and he's about a year away from being eligible for Medicare. And he went on to this insurance, and I'm not going to use any insurance company names because I'm going to talk really badly about this insurance company, and I don't need them having their general counsel send a letter to me telling me to cease and desist. But I will tell you, it starts with care. Um, and they are one of the most substandard companies I've ever seen. The when you are chronically ill, it is so important, even when you have to think about your budget, to find an insurance that doesn't use a gatekeeper, that doesn't limit your access to specialists or require you to get these referrals in order to be able to see who you need to see. Medicare Part B, if you have paid your taxes throughout your life, you have earned a right to be on Medicare Part B. You've earned automatically Medicare Part A by paying your taxes over 14 quarters of working throughout your life. But Medicare Part B is a gold standard when it comes to care because there's no prior authorizations. Now, somebody may tell me that there's a limited number of services for Medicare Part B where you do have to get a prior authorization, but I think those are in certain very specific type of service areas. And it's a limited number, maybe a half a dozen things at the most. Medicare Part B is the gold standard, as I said. You do not have to have a primary care physician who makes a determination as to when and to whom you can receive a referral to. They can't limit your access to diagnostic services. They can't prevent you from getting a CT scan or an MRI or a PET scan. They can't tell you whether you have to go to Quest or you have to go to LabCorp or you have to use another independent, group. Medicare Part B does not limit the access to care that seniors deserve and that seniors require. Because as I've said many times in court, there is no such thing as a healthy Medicare beneficiary. They all have something wrong with them and they all deserve to be treated. The problem that we have is deceptive marketing tactics that take place by these managed care organizations. And when they put people who have been on TV for years, like JJ Walker, or they put people on TV like Joe Namath, who were superstars, and people can resonate with them from the 60s, the 70s, the 80s. And they say, well, Joe and JJ would never lie to me. I'm going to get free rides. I'm going to get free hearing. I'm going to get free dental. I'm going to get free meals. I'm going to get, folks, please listen to me. Nothing is free. Nothing. And going on to a managed care plan as a senior, even if you take one medication like a high blood pressure medication, it is a bad choice. And I know that there's going to be people listening to me and they're going, but Sean, you don't understand my financial situation. And you're right, I don't. But I understand the financial situation of seniors because I have an 83-year-old mother who waits every single month for the 17th to arrive so she has her Social Security check. And that Social Security check gets smaller and smaller because the costs associated with prescription drug care, the costs associated with Medigap insurance, and the costs associated with Medicare, the increase that these seniors are getting on their Social Security is not keeping pace with inflation. We have had hyperinflation over the last 4 years. People were like, oh, it's down to 3.5%. Hey, wake up, geniuses. We were at 1%. We were actually below 1% for 4 years of inflation. So 3%, yeah, it's come down from 20%, but guess what? It's still not a good situation. Please, please, please advocate for your patients. Help them understand why they need to stay on Medicare Part B. It's not only beneficial for your practice, it's not only beneficial for your hospital or your health system, it is beneficial for the quality and access to care that the seniors require. Medicare Part C is administered by private organizations like United, Humana, Aetna, Blue Cross Blue Shield. These are private organizations that are beholden to their shareholders. You just heard Paul talk about it. Their shareholders at Aetna are not very happy with them right now. These organizations are statutorily obligated to comply with Medicare on what is payable under Medicare Part B, but they have a wide range of discretion for non-covered or excluded services. Their appeals process is not the same under Medicare Part C as what you find under Medicare Part B. It is a strain on the system, and pushing people from Part B to Part C is not the answer. And if I were given the opportunity to become the administrator for the Centers for Medicare and Medicaid Services under the next administration, I would push very hard to start bringing people back from the Medicare Part C world into Medicare Part B to ensure our seniors get access to the quality care, because we're giving access to care to individuals who aren't necessarily legally entitled to it. And I'm not getting political, but there was a great article out there about what's going on with overstressing the Medicaid system right now in hospitals. And whether you're on the right, the left, or in the middle, you need to educate yourself and you need to understand what it is doing to our industry. This is not
Sean,
a red or blue issue. Go ahead, jump in.
I wanted to interject just for 1 second. So this is a really great place to talk about, even in our proposal, Medicare has reiterated that they're moving everybody to Medicare Advantage, or their intent is by 2030, good, bad, or indifferent. However, in light of all of those OIG reports, and I think we're at about 32 of them, OIG reports on Medicare Advantage, and what they found, patients are not pre-scheduling appointments for 2, 3, 6 weeks down the road in order to have a heart attack in the office. That just doesn't happen. But the other thing that came out of all of those was the change from version 24 to 28. And so a lot of providers, they're out there treating patients and they don't really know that these changes have happened. They actually took away over 2,000 diagnoses that used to have value that no longer have value under version 28. And under version 28, they took away those forever codes. Previously under 24, it was alleged by some of the Medicare Advantage plans that we should automatically assign diagnosis codes for conditions just because they exist, whether they're treated today or not. And that was one of the things that those reports really shined a big light on, was that's not how correct coding is. We only code for those conditions that are being treated today. And so the official change from 24 to 28 actually states that those forever codes, congestive heart failure, those types of things are no longer added unless they're treated today. Not to mention the crackdown on depression, the crackdown on dependence diagnosis that were so overutilized during the version 24 years. So I think that while we talk about the changes to Medicare Advantage that have been talked about last week, like Paul was bringing to us, I think it's also important that we remind listeners that our payment for Medicare Advantage plans, those risk adjustment values, those RAF scores or Medicare Advantage scores, those are seriously being impacted by the version 28 changes as a reflection of what we've learned. And so hopefully that's going to make a big difference in some of the advantage that Medicare Advantage was taking in the past. Like that was great, right, Stephanie? And that that maybe that might be the saving grace. Unfortunately, it is
I have a
taking
comment too.
a big act on that Congress is going to have to get in there and give us a little bit of a hand with it. But Terry, I'd love to hear what you've got to say
jump
about
in, Terry.
this.
Thanks for being patient.
Yeah, no, it's no problem. Well, I just want to be not devil's advocate, but just on the there is another position on the Medicare Advantage. My husband's on it. He's a lot older than me, so don't think I'm heading that direction right now. Just want to put that out there. I am nowhere near 60, but anyway, only not in my mind. What I wanted to just comment on is Medicare Advantage, I think, was really for the healthy Medicare patient. They give things like gym memberships, and they give them, I know he gets, what does Tom get? He gets like $45 a month to get things at the pharmacy, like sunscreen or Tums or, over the counter things. And he gets, seriously, he's just like, I just order it and they send it to me and they give him like a little amount. He can go to any gym he wants to go to. There's just little things like that they can do. And then he also, some of his medications only has 3, but once blood pressure is less on the Medicare Advantage, then it would have been where he would have had to have a Part D or, a different plan for that, because Medicare Part B doesn't cover medicines. But here's also the other thing, is that one of the things that I've seen with Medicare Advantage is that I think a lot of patients who were with their physician and then became Medicare eligible, they now picked a Medicare Advantage plan that was a lower premium, lower cost, because it does have some advantage there than what their premium is for regular straight Medicare. And they could stay with their same physician who was also part of that plan. And it also helps for if you're, excuse me, dealing with some inpatient things there. But in saying that, I remember when my father was alive and he was put into a skilled nursing facility for a bit, they kept trying to get him to switch back to regular straight Medicare, because in skilled nursing facility, that, having Medicare Advantage is not a good thing when it comes to what they pay. They actually want you to have Medi, so Medicare, Medicaid, because that pays them a day per diem rate. And it's actually it's pretty good. It's almost $500, but it's better on straight Medicare than it is. So what I would just say is, when you're looking at these services or looking at policies, looking at plans, especially those of our listeners that are getting close to that, or you have family members, or you're trying to be empathetic towards patients who are trying to figure out, hey, I'm turning 65. What do you think I should do? Because I know they're coming to your doctors and asking you what should I do? And to Sean's point, Part B has very limited prior authorization situation. That's a very big positive. He's absolutely right. I think there's actually 4 that I know off the top of my head that they ask for. And Medicare Advantage is just like having an HMO, or just like having a, some kind of a PPO or EPO, where they have to get prior authorization for things. And always look at the language. Remember, they have to cover, or they have to, what do they call it, Christine? Where they don't necessarily, it's weird because how they word it. It's not that they have to pay for it, they have to actually allow it. So they have to allow it, but it doesn't mean they're actually going to pay for it, which to me is just insane. It's like how they allow certain preventative services, but they don't necessarily pay for them. They just say patient responsibility, but they do allow it to be done. And it makes
all the
my
time,
head
this
crazy.
quotation of benefits is not a guarantee of payment, or this
Right.
prior authorization is not a guarantee of payment. Nothing's
Right.
a guarantee of payment.
Nothing's guaranteeing a payment. So just make sure that when you're talking to patients about MAs, and also to Paul's point, versus the, straight Medicare, there's pros and cons to both, and it really depends on the clinical profile of the patient, what's better for them. And as Medicare, I know Christine said we're heading towards MAs for all. I think it's mostly value-based care is really what they're trying to head towards too. It's going to be a conversation, because how many of us, I know a lot of us are on LinkedIn, and that's where we see a lot of our posts for the OIG. It seems like Medicare Advantage plans, especially with the HCCs, the hierarchy codes, it seems like the MAs are in the OIG news. It seems like every day they're going crazy or taking liberties with overutilization of certain diagnoses that are not active. I know, Stephanie, you've got to see that in your audits all the time.
Yeah, and one of the things I wanted to mention, this is more so from my personal experience, but I find this very interesting. So I have an aunt, and she has since passed away earlier this year, but she lived in Florida. So, we think of a large population of people there looking at, potential coverage. And one of the things I found interesting, but it was never something I could really place my finger on, was the fact that her practice, for example, the medical practice she ended up going to, sent insurance related staff out to her house to go over benefits, to go over her conditions. And I can't remember if we talked before about this, but one of the payers that's been in trouble was due to the fact that they had a staff member, an employee, going into patients' houses, doing some kind of, exam, really on a nursing level, not at a provider level. And then, stating, oh, these are conditions they have. But at the time, to my aunt, it all seemed great, because they even, and this is going to sound crazy, it's not a major payer either. I had never heard of them before. I had to research it, and then I found that the office was a part of the insurance plan, but they had things like a beauty salon at their place, so she could go get her hair done, she could get her nails done. They would rent out movie theaters, they would do community dinners. So in my head, I'm like, okay, nail care, are they billing debridement? For the community dinner, are they billing dietitian? I don't know what they were doing from a billing perspective, but what I do know is when it came to the actual care of her, she did end up being very sick, had a lot of chronic conditions and things complicating her health. A lot of things weren't fitting together. You could tell the office was there to pump out the patients, to, do things probably to maximize what they're receiving as a part of the insurance plan. But, just be careful as far as the way that you're approached by the companies as well. If they're wanting to come into the house, why are they wanting to be overly helpful? That's really the question I would be asking.
It seems like there's I don't know, Paul, maybe you could, I know you might have seen this, but concierge medicine seems to be somewhere they're trying to pull some of that, like you were saying, the hairstyles and, like my husband's gym membership, he loves that. He just is like, I don't have to pay for that. I can walk in anywhere, show my card, United Healthcare, Medicare Advantage, and they're just like, oh, go right ahead. And, because he's a healthy Medicare age person. And so it's just interesting to me where, as we haven't ever talked about concierge medicine, so for another time, but it seems like they're trying to pull some of those things into the Medicare Advantage plan. And to Stephanie's point, I don't even know how they bill for it, because I know that people that get those services, they don't have to submit a claim. They just show their card and then that's taken care of. And let's face it, people don't care if they don't have an out of pocket.
Yeah.
They're just
Well,
like, do what you want.
Yeah.
Here it is.
yeah, there were a lot of good points made by the other people on the panel. I'd like to just hit kind of a bunch of them and just wrap it up because I know we have a full agenda today. The first thing, going back to Christine's point about version 24 versus version 28, I will remind everyone again, this is the clinical modification for ICD-10 in the United States. If there wasn't an insurance-based reason for it to be this large, it wouldn't be this large. Whether it is from an actuarial basis of saying we notice people in this zip code with this condition more often than people in this zip code with this condition, so your premiums are going to go up, or a nice little way of inflating data under Medicare Advantage plans by obfuscation because the coding set is this big. It only got this big with insurance input, and large builds confusion. So that's the first thing I would say. As far as your point, Terry, about healthy patients versus non-healthy patients. Well, concierge medicine seems to be a place where these physicians are looking for the healthy patient. It's like, you're going to give me a lot of money on an annual basis for me to tell you that you are extremely healthy. And once you get sick, I need to pass you off to somebody else that takes insurance or that does something, that can do something other than bringing you in for a 1-hour visit at very inflated costs that's outside the insurance realm. And suddenly we have a brand new healthcare status. I mean, everybody always wants to take care of the healthy patient, but to Sean's point, 65 and over, that's not a healthy population. And the reason why we have Medicare in the first place was because originally, and I know that nobody is old enough to remember this, but I'm being a student of history. The reason why Medicare was designed is that the insurance industry didn't want to care for these patients. They didn't want to accept premiums that were below value for patients who were constantly going to be getting sick and who are dealing with the effects of aging on a regular basis. So Medicare stepped in. And, Medicare, to Sean's point, is the prime payer. And the biggest testament to the success of the Medicare program has been the expansion of life expectancy in both men and women since the mid 60s. I mean, it took a little bit of a step back under COVID, but it was in the mid 60s at the time. And now it's roughly 74 for men, 77, 78 for women. That's a testament to the success of the baseline program. And as we get further and further down the Medicare Advantage rabbit hole, it begins to challenge a lot of the things that made Medicare a great program.
All right. Listen, I think this was a great first part of the conversation. I think we had laid out some solid understanding, hopefully, for our listeners as to why we are spending the first half of this program talking about Medicare Part C. So let's transition now and let's spend the next little while, Stephanie, jumping in and let's talk about RPM services. So first, for those who are not familiar with RPM, let's talk about this remote patient monitoring, what it actually is, why it was created, how it's used, and then we'll get into some of the nitty-gritty behind it. And I know Terry and Christine and Paul, you guys are Terry shaking her head no. All right, Terry, I'll let
We
you off
wish
the
we
hook on
didn't
this
know,
one.
Terry, right?
All right, I will let you guys have this one. Take it away.
Okay, so really quick, an overview of what RPM is. So, remote patient monitoring is basically this system. And first, let me say this was started in 2018, but it really inflated and became a larger program for either practices to integrate into what they were already doing, or like we've seen with a lot of other things during COVID, they were starting up companies just specific to RPM. So, right now, where we stand today, there's a lot more patients that are being followed under this than it was in 2018 when it started. So with RPM, the way that it works, you're supposed to get consent with a patient, talk to them about, the chronic conditions they have. They need to have at least one chronic condition that needs to be monitored on an ongoing basis. Most commonly, what I see are things like blood pressure, so hypertension and diabetic patients that are being monitored in this way. And the company or the practice who's billing it is supposed to supply devices, which this is a large part. There's supposed to be a cost to them with the devices, with the supplies, things like that, to monitor the patient. It needs to be automated. So I've also seen a lot of people who are manually having nurses input information, which doesn't meet an automated process. And then another part of that is the physician or provider oversight, whoever's billing this out. And then also their intervention in their management. So if something's wrong with blood pressure readings, with glucose, what are they doing about it when they find out that this is an issue? So for me right now, I've had a lot of conversations this year around RPM, CCM, all the various things where we're looking basically at monthly billings. And one thing that I'm realizing is that practices and organizations are not understanding that when we're looking at something like physician involvement, for example, we're not looking for them to be there just to check a box. And, I know that I've talked with practices in the past that had companies that were only RPM companies that didn't have their own physicians or anyone on staff, who basically needed their order and physician involvement so they could bill what they were doing. But now what I'm seeing is practices and organizations do have staff internally, but they're still not fully grasping the concept of what we need for medical necessity and how to complete all the components. So where I'm at today, I'm dealing right now with a client, and I'm really trying to get them to understand the basics of medical necessity surrounding this, and then really trying to dig in between the lines that are not written out for us by CMS or HHS. And over the past, I think maybe the past year, Christine, I know you're really familiar with this too. We've had some more information given to us, but we still have deficiencies. And Christine and I talked about this a few weeks ago or 4 weeks ago, where the OIG has now come out with a full report on a review that they did. And to me, this report is gold because it's giving me more insight into what's going to be thought of if my client experiences issues in the future. But what I'm running into is the client wanting to stick to very gray, vague guidance from CMS, twist it to their workflow, not understand why I'm saying, you need to hire this additional person. At one point I was having a conversation trying not to offend anybody, but asking, what does the physician do? If the physician doesn't want to do a visit to initiate with the patient, the physician's not following up when a problem is found, what is the physician doing? And they're coming back, and saying things like, well, CMS doesn't say that they have to intervene. So they're monitoring, and then they want to kick the patient back to the PCP who's not involved in their RPM program. So there's a lot of disconnects there, but I think this also sheds the light on a lot of what we deal with when we don't have very clear guidance and we have to sift through. Sometimes we may go into the claims processing manual or the NCCI manual or different things like that to find our information. And I had said to Sean earlier, I'm kind of at the point where I feel like all I can do is give them solid proof of what I'm saying, and it's still going to be up to them to make that choice. And I know if they don't listen, it's going to kill me because I know what the potential outcome could be, but I also can't control, what they're considering and how they want to interpret that.
One thing, Stephanie, I noticed with, and I said no, I wasn't going to talk about RPM, but this is a general statement. I know Sean's gonna be like, Terry. Um, is I notice that I get a lot of questions, and I'm sure you do too. I'm sure the whole panel does. I shouldn't say questions, it says statements, where people say, okay, well, where's that in writing? And sometimes it's a common sense thing. It's not, you can't find a negative in writing where you can't necessarily do something. Sometimes CMS will come out, we call it Medicare speak, and they'll say, this is what we don't want to see. And we saw that a lot with the G221 too. But sometimes you really don't have it in writing to tell them what they can or shouldn't be doing, or what they can do, because it's a common sense thing. And I've actually been in a couple of meetings with a couple of MAC carriers that I've been auditing for, and they've had the providers sitting across the table when we've kind of gone over some of their audit results, and I've had the providers say, well, that's not in writing. They said, yes, but read what you're trying to report and why you're reporting it. And they always bring me back to the first thing that Sean Weiss has said about everything. And I know we've all said it, but it always resonates with me when Sean says this. It's not always about policy. It's not always about the code. It's about medical necessity. And that's the first thing. And medical necessity seems to be lost in a lot of this stuff. And it seems to be that, especially in RPM, I've seen that they're doing it just because, like Stephanie said, they can, or the rules aren't 100% crystal clear, or it's very ambiguous in what they're trying to say. And I think you have to come back to that. Why is this medically necessary for the patient? And then go into the other stuff.
Well, Terry, it's like looking for the rule that says, don't put your hand on a hot stove. There is no rule to say, don't put your hand on a hot stove. Why would you put your hand on a hot stove?
I love
right?
that one.
So I think that that's a great analogy when we're talking to people about don't do dumb stuff. Does it have to be written down for you to know that that's not a good idea?
Well, so, it's funny, so I love the fact that you brought up the medical necessity things, Terry, right? Because this morning, Stephanie and I, first thing this morning, the very first meeting we had was a physician with his attorney who is not yet a client, who wants us to take on a payor in Pennsylvania and another payor in New York State regarding policies that have been in place for an extended period of time on specific types of services that all of a sudden, without notice, have been changed. And they've been changed to benefit the payor, not to benefit the patient or the provider. And when I say not to benefit the patient or the provider, let's clarify what I'm talking about. Because we don't want things to be created in a way that it's for the convenience of a patient or a provider. But we don't want to limit access to medical care for a patient because we're putting profits over care. And it seems that's what's happened with these two payors in Pennsylvania and in New York, where they have gone against generally accepted standards of medical practice. So what does that actually mean? Generally accepted standards of medical practice means that we have information that has been peer reviewed, that this is what is generally accepted in the industry when we have patients that are suffering from these symptoms, signs, conditions, diseases, whatever it is. But you also have something, and I know we have attorneys that listen to this. So before you post something about, nope, you screwed that up, Sean, let me say this first, okay? We have the treating physician rule. Yes, it was removed from Social Security several years ago, but it is still effectively used during administrative law judge hearings. It is still effectively used in district court, and it is absolutely an accepted standard for arguments in federal court. What is the treating physician rule? Very simply put, if I am Stephanie Allard's treating physician, I have evaluated her, I have created the plan of care, and I am carrying it out. I am her treating physician. The courts have indicated that the Secretary of Health and Human Services is required to give deference to the treating physician even in the face of contradictory information. Why? Because healthcare is an evolving platform. There's a reason why they call it the practice of medicine. Medicine is not an exact science, it's an art. And anyone who doesn't understand that, you may be outside of the industry. So we argue what medical necessity means. And Terry, you're so right for bringing this up, because we have what is referred to as the as medically appropriate and reasonable standards. And if I'm going from memory on this, I know it's chapter 3. I think it's section 3.2.4. I know Pam Vanderbilt is listening to this today because I saw her pop up on the feed. If somebody wants to check that out, I think it's 3.2.4. If I'm wrong, feel free to correct me. But the first thing that it says under the appropriate and reasonable standard is that the service cannot be experimental and or investigational. Well, if a service is not investigational and or experimental, then medical necessity has to be left to the clinical judgment of somebody that has a piece of parchment on the wall behind them that says MD, DO, NP, or PA. Now, I'm sure there's other clinical designations that clinical judgment applies. I'm speaking in general terms here. So you're right. It has to come down to medical necessity. But medical necessity has to be established through clinical judgment, except when we are talking about coding, billing, and documentation standards. It is extremely interesting, and I'll leave you all with this, and then we can wrap up this discussion. I have a federal criminal trial coming up where I am the testifying expert. A motion to exclude was filed because the DOJ, and I hope you guys are listening to me, they are tired of losing because they don't do their research. They don't spend the time to get bona fide subject matter experts. They put these pinheads onto the stand. And I hope you play this in court. The bottom line comes down to this, okay? When you want to exclude somebody, and this is on the medical necessity issue, make certain that you are well aware that the Office of Inspector General published an OEI study that indicated they contracted with certified professional coders to determine the medical necessity and the appropriateness of the CPT, ICD, and documentation for the encounters that were reviewed. So before you file your Dalberts and you file your motions in limine, do your research. Okay, let's move on from that. I'll get off my soapbox. I get so tired of having to write these responses to these prosecutors who shouldn't be prosecuting cases. And I feel bad for these young men and women because they may get one healthcare case every few years or maybe two. Very rarely do they ever see the inside of a courtroom. It's kind of like that scene in A Few Good Men when Tom Cruise turns around at the end and he goes, "So this is what a courtroom looks like." That's kind of what it is for some of these prosecutors today. All right. I'll give you guys the last word on RPM. So it's 30.6.1B. So I was close. It's still chapter 3. So it's 30.6.1B. Thank you, Pam Vanderbilt. It's always good to have you on. All right. So let's wrap up RPM and then let's dive into what I think is going to be a great conversation for the last 16 minutes. And that's talking about the issue that you brought up, Terry, when you were circulating issues to talk about today, which is federal, state, and not understanding guidelines.
Well, I'm going to jump right in. I don't know if we have more on RPM. I think we kind of wrapped that up. But here's one thing that I think is, or a couple things that I think is important. I think when a lot of us are looking for regulatory guidance, published guidance, and kind of goes to what we were talking about before, where sometimes you just don't find it. But when we do find it, remember if it's Medicare or CMS, that's what it applies to, Medicare and CMS. And even though people call it the gold standard or the only standard, and trust me, I'm one of them that I like it when I find something that's Medicare, because then I look to see if there's also a commercial payer policy that either coincides with it or at least has a lateral meaning. A lot of times there isn't. But we have a lot of areas where we have to not just look at the federal response or the federal position on things. We have to also look at your state. And I'm amused by this sometimes in the conversations I have with my good friend Christine Hall, because her and I have worked on so many projects. We actually have another one coming up, and she's in Florida. I'm in California, the two insane states in the country. when I talk about insanity, I'm talking about policies. And we have, I mean, for example, in California, what an NP, a nurse practitioner, can do versus what a PA can do from a supervisory position is totally different. PAs are a little bit, I don't want to call it stagnant, but they're a little bit handcuffed. How about that? As what they can do, because they have to be under the physician, MD or DO supervision. But an NP, you can go open up your own practice, or I'm sorry, a nurse practitioner, NP. You can open up your own practice as long as you have a supervising physician within a certain radius. And it's just different. I know a lot of people during the pandemic, and this was just a nightmare, is they kept going by everything that Medicare and CMS kept putting out on that fee-for-service list that kept changing. It went from 16 pages to, I think at the very end, what was it, 282 pages. They kept adding and adding and adding new things. And people were trying to bill E&M services, office visits for audio only. And I'm like, no, the only state that allowed that was Arizona Medicaid, and it was only for 90 days. And so you had to really dig to find things. And, I know Christine's got some really funky rules in Florida as well, but people seem to
Well,
forget.
one of the funky rules,
Well, let me just
Carrie,
finish real quick.
go ahead.
Yeah, we have the United States of America, meaning that the federal government is here, but then they give all the states their autonomy to, I mean, just look at what the change with Roe to determine what's going to happen. And the other thing is that 2 years after the pandemic hit, CMS put out a statement. It made me so angry, and it's in everything that we've done with telehealth. And it said, well, even though we said you could cross state lines, we meant if that state said it was okay too. And so all these providers had done it because Medicare said you could do it. But then they rolled back what they said 2 years later and said, well, just kidding. We just meant that if you were in that state and you also read those guidelines, that you could do it. And we knew Florida was a champion on this in 2021. They're like, okay, we're done. Now you either have to be licensed here or you have to come back in person. And now, Christine, I'll defer to you, but you and I have talked about, and I called Stephanie on my vacation last week when I was in Hawaii going, hey, I have a state or I have an issue here that doesn't sound right for where I'm at, but this client is here. What do you think? So again, Christine, what you're dealing with state issues as well over payer policies.
Absolutely, absolutely. And we know that Florida is a big hot mess. However, I was talking to Kimberly Jo Williams a couple of weeks ago because her internal policy with her organization was for telehealth services, they needed to get consent for every patient. Now, Medicare has said that if you have one consent, that's okay. Then you can continue the telehealth relationship. Well, in digging, we found that the state of Texas requires every telehealth visit to have consent. So it didn't matter whether it was Medicare, Aetna, Cigna, TRICARE, whatever it was that you're doing telehealth, if you don't have consent, it's not a billable visit to any payer because it's not a true legal visit. So I think we have to remember that. In Florida, a lot of people didn't realize, but those NPs that could work autonomously, they could not provide supervision for medical assistants in their office, assisting them until the end of our pandemic. It was 2022 that our legislation finally increased the supervision for our NPs we were coming out with this, wow, now NPs can supervise MAs. And I literally had dozens of NPs go, supervising our own MAs since the beginning of our practice back in 19 blah blah blah, not realizing that we have to make sure that we're not just focusing on the federal laws, but we're also very much involved in our own state laws that could trump some of those federal requirements. Again, Medicare requires one consent on file. Texas is going to require it on every single visit.
Right. And then in Michigan and in Montana, I was looking it up just for medical assistance, just for example. Michigan allows a lot of liberties where they can do injections and they can do things under general supervision, where you go to Montana and they're like, not so fast. You better have that doctor in clinic. So the state issue, it's such a really big deal. And I talk to coders, billers, administrators, a lot of healthcare professionals, and I'm astounded by how many people have never read their state code. They didn't even know there
Well,
was a state thing. I am shocked.
Terry, one of the things that this past week I was at a conference, and one thing that we talked about quite a bit was how much we believe our providers know everything. And where I found a lot of staff members like, well, my doctor told me to do this. My doctor said I need to do it this way. And I think that what my recommendation is, it's always okay to say, can you show me where it says that so I can do it the right way? Maybe that's not a very aggressive way to approach your provider and say, just show me where it is so that I know that I can do it the right way. Because again, sometimes those providers, they're just having impromptu conversations in the hallway, passing each other. Hey, I'm doing this now, and I'm doing that now, and I'm making a pot of money. That doesn't say that I also made sure I reached out to my healthcare attorney, or that I spoke with my administrator or my internal compliance program. We approved these decisions. So I think that that's something people need to realize, that although your doctor, we all respect them, or we respect our employers, but they may not know all the nitty gritty, the state, the federal requirements. And it's not a bad idea to start asking to see where that's located, just to protect yourself.
Well, and also if you don't know where that is, look audio only. Look at your malpractice insurance. How many malpractice companies for physicians? Oh my gosh, I know Stephanie and I have talked about this. I don't know if Paul, you and I have, but I know it's come up in conversation. They're like, we don't cover that. What are you doing? Go out of state. And I'm like, well, did you first check to see if that state allows you to go out? And then I have, oh my gosh, it's my favorite one lately. And I'm not trying to say that, I'm not trying to be flip about this. I'm really not. It's really what we're dealing with on a daily basis that we're having to, I don't want to say come to your rescue to the listeners, but having to let you know, you need to take a step back and make sure that you have all of your, I's dotted, T's crossed. Otherwise, this could come back to bite you, really, not just from a malpractice situation, but from a trigger, an audit from a payer. And it's all about the money. I realize that. But compliance is also a factor here because it could really hurt there. But I have doctors saying, well, the Medicare rules say that I have to be, for the most part, I have to be licensed in the state where the patient is. It doesn't say I have to be licensed in the state where I'm at. And I'm like, what? Of course you have to be licensed in the state where you're physically at. And doctor said, where does it say that? I said, that's common sense. And so then I said, okay, let's talk to your malpractice carrier. And I mean, seriously, their malpractice carrier. And I was talking to not just a customer service rep. We went up to their provider rep, which was a couple of tiers up. And they're like, are you guys punking us? Is this really a question? And that's what they said. And it was an attorney I was talking to. So, there's federal, there's state, there's payer policies, there's malpractice policies. And there's just so much out there that you have to make sure that you have all of that information. It's an information flow. And Sean and I, which you'll hear this tomorrow on our hashtag Terry Tuesday, ignorance is not bliss in healthcare. You can't pretend that you just didn't know.
That's right. And, one of the things that, and I don't want to give any strategies away, but one of the things that I would love to be able to do for a federal trial, especially a criminal trial, is to print off in 3-ring binders the Health Insurance Portability and Accountability Act, all of the special advisory opinions that were published by the Office of Inspector General, all the guidance that has been published by the Department of Justice, print off Code of Federal Regulations 42, 3729 through 3733, print off the United States Code, 18 USC, you know, the specific sections for healthcare fraud, print off OSHA, print off laboratory compliance for those that have in-office laboratories, and then print off all of the local coverage articles applicable to that organization, all the national coverage determinations applicable to that organization, all the local coverage articles applicable to that organization, and then go to each and every single one of the commercial insurance companies that they participate with and each of the plans and print off the individual medical coverage policies. Put those in, see how many carts it would take for us to fill. And right as I get ready to walk up to testify on behalf of the defense, wheel all of those carts up and put them right in front of the jury booth. And after they swear me in, have the first question be, Mr. Weiss, what's in all of these 47 carts that are in front of the jury? And then just explain to them, that's what physicians have to know in order to get paid for a patient presenting with a cough. I mean, think about that. Between us, we have 200 years of experience, okay? But think about this. Could you imagine how overwhelming it would be for non-initiated individuals into the healthcare industry to have to sit and look at 47 carts full of binders to understand the simple concept of you don't feel good today. You want to see your primary care physician. Well, these are all of the things that your doctor, nurse practitioner, PA has to comply with in order to get paid for the services and not have them recouped and not violate some kind of law, whether it be Stark, anti-kickback statutes, coding guidelines from the American Medical Association, the Medicare administrative contractors who are contracted to the Centers for Medicare or Medicaid Services, who has their own idea about promulgating national coverage determinations into the law. Could you imagine how that would play out in a courtroom? But that doesn't detract from the conversation here today, because I agree with Terry, Christine, 100%. Ignorance is not bliss. You cannot say, well, I just didn't know, because the government's response is, you should have known. It's in the public forum. It's in public domain. Healthcare, especially when it comes to compliance, there is no absolutes. There's no black and white. It's shades of gray. The best we can do is to put forth a good faith effort to comply. We may not always be able to keep up with every single change that's released in a policy, every code change that's released, understand every it, thus, then, the that changes in the definition of a code that could significantly change the context of a procedure or a service. But as the Department of Justice says in the evaluation of corporate compliance programs, those organizations that have established a culture of compliance, that are making a good faith effort to comply, that are putting forth common sense approach to dealing with regulatory compliance, even in the face of getting something wrong, it doesn't necessarily mean that it's going to rise to the level of fraud, waste, or abuse. And remember, I'll leave you with this. Prosecutors have said they are less likely to prosecute an individual for fear that they cannot convince a jury of one's peers of wrongdoing if a good faith effort has been put forward by that individual to try to comply. Imagine during an opening statement from a prosecutor where they say, we're going to show you, because we have the burden of proof on the prosecution side, right? Beyond a reasonable doubt or a preponderance of the evidence, depending on whether it's criminal or civil. We're going to show you that Shawn Weiss committed fraud. Well, Paul Spencer is going to get up on the stand and he's going to point to 47 carts and go, I don't know that it's really fraud because there was no intent. Don't know that I found in my audits that I performed any knowledge of submitting claims that were wrong. But I mean, I don't know. You figure it out. There's 47 carts of policies, procedures, laws, statutes, acts, regulations. And don't forget, we just had Chevron overturned, which means the courts can no longer give deference to non-binding payer guidance. It's called subregulatory guidance. The courts now have to give legal analysis rather than giving deference on general guidance from the payers. So that's my little bow on that. Anybody have anything else on federal, state, local, or commercial payer guidelines?
One last thing.
Yeah.
We don't get to pick and choose. So we look to federal first, then we look to state and look to see what's more strict. Also thinking of the MACs that are in play. If your MAC says something, you need to be following that. I actually had this question last week is, somebody sent over what their MAC says and they didn't really like it. And they said, well, the others don't say this, but mine says this. It's not optional. Terry, I know. Yeah, you need to pay attention.
I'm sorry, I can't stop laughing. I don't really like that.
The payer may pick and choose what they're going to use, but we do not have that option on the provider side.
Well, it's like us. We can't pick our relatives, but we can pick our friends. So pick and choose wisely, folks. All right. I think that's going to wrap it up for this episode of The Compliance Guy. I want to thank Stephanie, Christine Hall, Paul Spencer, and Terry Fletcher for joining in today. And I want to thank each and every single one of you for tuning in, logging on, and hanging out with us. Terry and I are going to be back tomorrow with a brand new #Terry episode. We can't wait for you to join us then. I'll be back on Thursday with an incredible interview of a physician who was just acquitted on more than 30 counts in federal court on a case that our firm got to play a significant role in working with the defense to help them show the jury why this doctor was not guilty, and the jury understood the arguments. So that will be on Thursday this week. Looking forward to bringing you these new episodes coming up in the following weeks as well. So until then, remember, be good to yourself, but more importantly, y'all be good to each other. Take care. Sweet. Great episode, guys.